prior to ARC getting involved for them to go to treatment, because it cannot be an involuntary admission.
Yeah, we can't hold anybody involuntarily.
Right.
So we don't have an analogous law in Kentucky. We have something similar. It's called Casey's Law. So a judge will order someone to treatment. But if they decide to leave, we can't restrain them or anything like that. So we do have a lot of success with Casey's Law clients, but we're going to work through some of those specifics with Virginia law enforcement. It's something that we haven't dealt with before, but we're very interested in being involved. And like Dana said, we think that there's a lot of folks who are getting a TDO order that might be more appropriate for like a Casey's Law type model, where they go through our treatment, but not necessarily involuntarily. So it's kind of a diversion there, so it avoids law enforcement on the front side. That accurate?
We appreciate it. Thank you.
Terry Ruth. I'm the administrator at the local hospital here in Dickinson County. And I was wondering, of course, just like Jeremy said, we have a lot of patients that are TDO, but we do have voluntary patients that come through our ER as well. Would that be something that you guys would be interested in, as far as being able to take that person from the ER as long as they're voluntary?
Yeah, absolutely. Also, another leg of my team, we have what's called treatment placement specialists, and so they work with the hospitals, like with the discharge planners, with the nurses there, with the emergency rooms, and so them, and combined with the community liaisons who are actually out in the community, boots on the ground, we take clients from hospitals all day long, every day. Yeah, so that's something that we'll definitely be setting up with you. I'm glad that you're here. Maybe we can exchange information before I leave. But we want to make sure that your clients your patients have somewhere to go, because oftentimes when they come to you, they have nowhere else to go when they leave besides returning into a bad environment. And so that's very important to us.
That is one reason. I worked in a local ER also before I came here, and that is one reason that I wanted to come here, because I wanted to be part of the change in that, because I would see that all the time, that they wouldn't have anywhere to go. So that was really important to me, that we worked with hospitals. So I hope that we are able to work with you.
Yes, ma'am.
I hope you can hear me okay. I'm not known to do anything but rumble sometimes. But first off, I'll have a kind of a statement and a question also. So as a community partner of mental health, first off, I want to say thank you and welcome. When I heard that you guys were coming in, I kind of dove into researching your model, and I have to say, without sounding too giddy or fangirl, I was so impressed. And as I've served the community almost roughly 30 years, so I can say, as many of the other community partners here can say, we've seen a lot of what doesn't work. And I'm very impressed with your model, very impressed with the thoroughness that it was developed and the ongoing adjustments you're making. So one thing I wanted to touch on was your community involvement, I guess. So we've got a couple private practices, we've got several community partners, and Dickinson County has been making a move toward a more cohesive effort in not just mental health but substance abuse. And the move's been slow, I guess you could say, to be the teamwork. But we have a lot of strong community partner resources, and we have the FAT team, which is fairly robust compared to other counties. And so one of the things I would love to hear about, because I was reading a little bit about it, but I'd love to hear about either your plan moving forward of community involvement or your history of community involvement, and including partners and resources we're already boots on the ground. And very happy you're here. So how can we be of help? How do you plan to use what's here?
Well, this is Vanessa's team also, but I'm going to take a stab to start. I want to recognize Letcher County again. The sheriff's here. They have a program that they've started. It's very similar. It's called HEAL Letcher County. There's an acronym there, and it is, the law enforcement is involved, the jail's involved. They have many of the providers locally are involved, and as you know, folks with substance abuse disorder, the problems that they face are not just substance abuse. like Amanda said, that you have mental health issues, you have housing issues, you have transportation issues. And so HEAL it sounds kind of similar to what you're doing here in Dickinson County, where you're trying to get, and it's difficult, by the way, for someone to navigate that ecosystem, right? You come into treatment and then you're, okay, well, you graduated and just go out the door. That's not a good plan for success. So to HEAL in Letcher County, and you heard those statistics that the sheriff talked about earlier. The community came together to address that, and ARC is a part of that program. They've invited us to be on their committee. And then in every community that we serve, in addition to the liaison who's involved with those parts of your community, we have a local advisory committee in each center. And basically what that is, it's stakeholders. It's a kind of an area where you can share information back and forth. And sometimes they meet monthly, sometimes they meet quarterly, sometimes they meet bi-monthly. It depends on what the community wants. But you have teachers, local, people who are interested who come there, and we'll do lunch and talk about what's going on in the center, what's going on in the community, going back and forth. And then we actually give a grant to that committee every year that gets spent in the community. And the only rule is they can't use it for something that benefits ARC. So you can't use it to like plant trees on the way to our facility or something. So a lot of times we'll do Little League, or we bought some equipment for the sheriff's office, I think, in Washington County this year. So you can talk more about that.
Sure. I mean, we do everything we can to be a great community partner. When it comes to other mental health or substance abuse treatment programs who are in the communities, we've always worked very closely with them. Oftentimes maybe a treatment facility is not a right fit for someone, and so we have those partnerships with them that they know our liaisons, and they'll reach out and say, hey, I think they need more than what we offer. And we know that you guys have a very strong mental health component, and we think that that's what they need. And so we'll get referrals from them, or if it's an outpatient program in the community and they need residential treatment for a while, they'll send them to us, and when they leave our program, we send them back to them. So on that side of the community partnerships, we try to be a very good partner on it too. But like John said, our meetings that we do out in the community every month or so. Like I'm over the one in Martin County in my hometown, and so we have business leaders, business owners. We have the county attorney. We have the sheriff's department, and we have all of the school employees, the ladies who got the resource center who work there, because we are oftentimes treating the parents of the children that they're treating in the school. And so trying to understand what's going on in the community and how we can partner with people to best support them, it's at the top of our list, because we want to always be a good community partner where we go, and we want to be giving back into the communities that are so, I'm excited about what comes out of Dickinson County, because you guys have been so welcoming to us, and so I'm excited to see how we're going to continue to be able to give back into your community like we do the other communities we're in.
The one thing I'd like to add to that is, I'm going to say a quote, but I'm not going to say who the quote is from, but it takes a village, and it's going to take each one of us doing our part. And so what I've become to realize in the discussions I've had with Mary and Freddie and Dana over the course of the last year trying to get this done is we got to include the community colleges, we got to include all the various agencies. ARC can't do it by themselves, and I can't do it by myself. And I truly believe that what we build in Eastern Kentucky, that we're starting to get the buy-in from a lot of different agencies, the university, the hospitals, the business folks. And so I always say it takes a village. And so we want to build the village over here and just include everybody in their village.
Greg, this is maybe just loosely related, but Greg, can you talk a little bit about how you've involved the hospital with optometry and dentistry within River Place? Because I think that's might answer some of your questions.
Yeah, so I went to the University of Pikeville because we do have a medical school there, and we have the optometry school, and starting in the new year, they'll have the dental school starting. And so I'll start out with the university. And so what I've convinced them to do, and you'll see in the slide or two on, so we've been since 2020, we've got a full optometry center in Miller. And so they send their students up as needed. They schedule schedule the patients when they can come over, and it's literally in the same building. and they can come over, and while the university's teaching their students, they're providing eye care and exams and actually making glasses and stuff inside the facility. And so we carried on to that with the medical program. And starting this year, their medical students in their third year of residency, or their third year of school, they've got to have 6 weeks of residency in mental health. And so we've got it set up to use ARC psychiatrists that can actually come to that center and either see those people and telehealth through to ARC psychiatrists and actually get a residency on site instead of having to travel around all over the state or other places to try to get that 6 weeks. We also have now in place the dental component. So we got a full dental clinic with 3 chairs. If you walked in, you'd look like a dentist office. And UPike's going to do the same thing as they do in their optometry clinic. They're going to have their students to come up and provide dental care. And I will tell you, we were talking about dental care, and then Tim and I were talking about it one day, and I didn't really take this into a factor when we were talking about it. But one of the biggest causes of relapse is their dental, their teeth problem. They went so many years of not having anything done to their teeth and stuff, and it goes farther than that because when they actually get prepared to go out to find a job and interview, you know, their teeth is in so bad a condition that they're ashamed. So this whole system of what we've been trying to develop in Pikeville through ARC is we want to duplicate these services everywhere we can because we think each one of those is a critical piece of getting these folks back into the workforce.
I also want to add on the medical side, we do a lot of, you know, when they first come in, they've not had medical care in a long time. So their diabetes may be out of control. You know, they might have to see a cardiologist, like you said, the dentist. They've not been to an eye doctor in forever. Like, and when I say forever, I mean like 20 years, and 20 years without the dentist, and 20 years without seeing a doctor. We do a lot of referrals to the community because there will be things that, you know, require an outside referral. And we work very closely with all of the offices and, you know, the facilities, the hospitals, the places local to each facility. It's a very close, you know, we have a very close relationship in all those places.
I think one of the things that we've experienced in Virginia, which is I'm sure is similar to Kentucky, is that a lot of our private facilities, especially the psychiatric facilities, they have such extensive exclusionary criteria that it's very difficult to find beds that are available to treat individuals that are not at the state-run facilities, and I just saw an article in Cardinal News, I think yesterday, that was touching on that, and that the state hospital system in Virginia is just completely overran with patients. Can you talk a little bit about ARC's exclusionary criteria for admission? Because from what I understand, you're willing and able to accept a lot of the things that we find are exclusionary in some other facilities. And then maybe a little bit about your infectious disease program.
I'll let you talk about that. Most of our exclusionary items are going to be on the medical side of things, so I'll let Amanda talk a little bit about that.
So as far as exclusionary, it would just be something that absolutely cannot be managed. They cannot care for themselves at all. They're not able to shower themselves. They're not able to, maybe they're still having suicidal thoughts. Maybe they're still having homicidal thoughts. That's generally, we don't have a lot of exclusions. I mean, would you agree with that?
Yeah, we try to treat everyone that we possibly can.
We have, we move, like, depending on, you know, if someone, we have several facilities, just like the River Place facility in Pikeville, it is one level. So if someone is using a cane or has a walker, you know, or has some sort of leg injury, that's the place that, you know, we want to send them somewhere that they can be successful. So we absolutely do that. And she mentioned the infectious disease. Almost, I shouldn't say all, but a whole lot. I don't know the statistics, I'm sorry. But our clients have hepatitis C and STDs, or STIs is what they're called now. So as soon as they come in, we are checking them for, we do some intake labs, and those labs include a hepatitis screen, an HIV screen, and an STD screen. So in that, we're able to treat that, even if someone does just stay 30 days, at least when they leave, they've had STI treatment, and it's just not out in the community. We have saw very, very good results with our GI program. They take, they're on medication while they're there. It gets them treated, and we just have a lot of success with it. I did not ever realize until I worked here how many, people had hepatitis C. I didn't even really realize that it was so treatable, and I also did not realize the prevalence of STIs. But they get that as soon as they get, we're checking that as soon as they get there. So we're able to treat that and get that in. And I think that's a huge help to every community in a roundabout way.
Yeah, when I was county executive in Garrett County, my county was one of 8 identified as could be an epicenter of a major hepatitis C outbreak because of our demographic conditions. And there were some harm reduction things that we took as elected officials, but one of the big things was this treatment. That these were folks who are working in fast food restaurants, working in the restaurants downtown, and hepatitis is a communicable disease. This is something that I think ARC is giving back in ways that affects those of us who are not in addiction. And one of the exclusionary things, we don't take sex offenders within the ARC program. That's something that I should probably point out. And then sometimes we do have some folks who are in acute schizophrenic auditory and hallucinatory. A little more.
Yeah, just if they're in psychosis. A lot of times when someone is using meth, they will go into a meth psychosis, and some of those clients we cannot take until that's resolved, which it usually is an acute condition, and it's resolved once the meth is out of their system. So then they're able to come into treatment.
Yeah. So that's something that our community liaisons would work with them. They would know, or they would stay in contact with the higher level of care wherever they would be treating their their hallucinations or whatever it may be, and then we will have a bed ready for them once they are stable and cleared from that level of care to be able to bring them in.
Yeah. So when someone calls the intake line, Vanessa's team does the initial assessment. If they're not appropriate for treatment initially, we'll try to help find them a place, and then the liaison follows up and can take them maybe from the hospital back to our treatment program. And that's really a breakdown of the system. Previous to this, a lot of folks would go to this other higher level of care, and then they would go back to the street. They would never come back for the substance use treatment. And like it's been said many times today, a lot of folks who are in addiction are self-medicating this other problem. They're in pain, either physical pain or some type of emotional pain, and they're just really self-medicating. So, if they're going to get to that higher level of care at the hospital, and then they're just back on the street, that's where we want to, make that connection right there on the backside. And our liaison is pretty good.
John, you may have mentioned this, or one of you may have mentioned this earlier. I apologize if you did, but can you talk a little bit about the folks who come to treatment by way of the court system and what ARC has found in relation to the success rate of those folks being in treatment versus someone who is not justice involved? It's interesting to me because as someone from the behavioral health field, it's what they found is the opposite of what I was always taught. So I think that it's an interesting.
Yeah, I would love to talk about this. So I always thought, and I've always heard, well, you have to wait till they're ready. They have to want it. And in fact, our data shows the opposite is true. And in fact, I love telling Vanessa's story, and I tell it against her will too. The first time that she came to treatment, the last time she came to treatment,
The only time.
it was against her will, and she did not want to be there, and she was kicking at the windshield, and it's a really horrible story, but the reality is she was our first client, and here it is all these years later, and she's still sober. And so what we found is that the majority of people, if they're going to leave treatment against medical advice, they're leaving within the first 72 hours and in the first 7 days. And so what happens with justice-involved clients, their average length of stay is significantly longer than folks who come in on their own. And the reason is, when you come into treatment your first few days, you might say, hey, I got a girlfriend or wife at home and I'd rather be with her, or I miss my kids, or, but I have a home to go to. And the reality is, if it's jail or treatment, they're going to stay past those first few days. Now, if you check yourself in, and we have this little saying that the 4 L's get you there: your lawyer, the law, your lover, your liver. Is that right? Are the things that lead you to treatment. But what we found is, if the alternative is jail, people are going to stay past those first 72 hours and past the first 7 days. And we have an enormous amount of data. We've treated over 60,000 clients since we've been open. And the reality is, a lot of these justice involved folks are staying long past their court orders. And I think that's really testament when they can get past that first initial shock of, hey, I got to share a room with a guy. I'm sure, there's rules here. I've got to make my bed. This isn't, just some camp where we're singing Kumbaya. There's a schedule here, and it's regulated, and we have rules, and you have to get with the program, and that's a little shock, I think, initially for folks. But if they can get past that first part of the justice involved clients, their average length of stay is significantly longer than people who come in.
Yes, ma'am.
Yeah. My name's Ron Sluss, of course. But, I have just one question. I think you mentioned a while ago that hepatitis B and C cannot be transmitted to only hepatitis A. Which I work on the health inspector. That's one of the 5 illnesses that can be transmitted through food is hepatitis A, not B and C. That's either through sexual contact or drug use. When you go into a restaurant, it can work if they've got B and C or HIV. You don't transmit HIV with food either. Then the second question I have, or I want to make mention of, I think I'm right, I need to check it out for sure, okay? What kind of jobs on economic basis we're looking at? How many jobs do you anticipate being available at the Wildwood facility? And what kind of jobs? What remains of the job besides nursing?
I'm going to tell you the number, and then I'm going to let Vanessa or John will tell you the top jobs. I think what we've seen is an average of 35 to 40 jobs in some of the other facilities, just because of the outpatient and the services. It could get a little higher than that. And I know that they've got that already. So I'm not in the treatment side, but I'm going to let John and Vanessa I'm going to tell you about the different type jobs they are there. The one thing I will say is what I've seen in my experience in the last few years, and what impresses me more than anything, is these people that are in there, they're held accountable by their peers. So these peer support specialists are, to me, is one of the major ingredients to make this thing work. When you go into River Place, and I occasionally walk through and stuff, and then you'll hear someone say, it's not because their employers or their head people, the directors have to go and watch over them all. They build that atmosphere to where they're holding each other accountable. And to me, that's a major success story in itself. But then I'll refer to them, let you tell you that.
Even if they've been there and they have a job, they are good for society because they're probably start paying taxes and maybe buy a house. But what kind of jobs are there?
Yeah, so to your first point with the hepatitis, it's an extraordinary cost to treat someone with hepatitis. So, there's, the fact is that there has been an enormous, we are treating an enormous number of people in Kentucky with that, and that's a great return on investment, I think, for the taxpayers. I try to look at things that way, and we're asking, insurance companies and taxpayers to shoulder some of that cost. When folks suffer the secondary health problems that are related to various types of hepatitis, those are things that we all bear that burden. Now, in response to your question, we keep a staff to client ratio in each center, and it's not only by the number of clients, but it's also by the level of care that they require. So the initial level of care requires, for instance, a 24/7 line of sight supervision that's not required with later phase of treatment with what we call our outpatient level of care. So for the RTC phase, depending on that number of clients, will dictate some of the level of staffing that's needed. So initially, we'll have a residential director there, we'll have a residential coordinator, we'll have residential staff that are there, we'll have nursing, we'll have various clinicians, we'll have case managers, there's maintenance folks. So generally, I anticipate 35 to 40 folks at Wildwood, but that's conditioned upon some of that level of care, what the level of care needs are. So, and Vanessa can tell you as we shift around based on the needs, we can adjust those beds. So there'd be 100 beds here, let's just say. I know it's a little 113, 114 beds. That's the number of actual beds with pillows on them. But we might say, well, look, our phase 2 census is growing larger than the phase 1 census, so we'll, you keep those proportions based on the group sizes, and we can kind of take 12 of the RTC beds and move them to the PHP beds. It's kind of a complicated mix, but generally 35 to 40 jobs would be my guess at the male facility.
Well, I'm sure you have to have therapists, don't you?
Yeah, the clinicians. Yeah.
What do you call that, Riley? What's your major?
Well, psychology and clinicians, you're gonna have to have some of them.
Yeah, clinicians is one of the things I listed.
Yeah, we'll have clinicians, we'll also have peer support specialists, we'll have office personnel, we'll have to hire additional people in our billing department to be able to do the billing for the services that we provide. We'll have to add transportation department here over in Virginia. We'll have community liaisons. We'll also have, I'd have to add members to our intake call center, which is all done from your home, and most of our billers are at-home positions also. So yeah, we'll have to add to all of the current departments that we have in order to be able to support the different services that we're providing here in Virginia also.
We will also have nurse practitioners, psych nurse practitioners, RNs, LPNs, CNAs, and then we also have healthcare specialists that kind of help coordinate medical, they go get clients for appointments, that sort of thing, in the medical department.
But really, you're talking about more than 40 jobs, because you were talking about that some of them will work from home.
Well, I'm talking about the people who work in the center. Vanessa's talking about the folks who will work the ancillary positions that'll be there. That's right.
Well, what about the average salary?
I mean, it's going to depend based on the position. I mean, we have competitive salaries for any of the positions that we have. So if all the cost analysis will be done by our human resources department, and so we will determine what the average pay will be for a clinician in this region, and then we will have competitive pay for that, as is for nurses. So we have our human resources department will do the cost analysis, so it'll be per job. So I would hate to say an actual average salary. I know I saw something out there that was around $45,000 to $50,000, but that would be combining our highest paid nurse in with our lowest paid residential staff member, someone who maybe has just completed a year in treatment and wants to come over here and work. So I would the average salary I don't feel like gives you a great picture, but we definitely have competitive pay. We will do the cost analysis for each different position in this state, in this region.
I think what we have projected and looked at over the past year, the average across the board is going to be somewhere between $35,000 and $40,000 a year. I don't think Vanessa's been included on some of the information, but when Freddie and Dana and Larry and I and Tim have worked on this stuff, the model looks like it's going to be between $35,000 and $40,000 a year average.
And again, it will vary just based upon position.
A lot.
I know, like when I'm hiring in the medical department, we don't have any issues with them matching salaries at other facilities. It always, we don't have any problems hiring nurses as far as pay goes.
Yes, ma'am.
I'm Peggy Kaiser, the Irvington District Board Supervisor, where Irvington Elementary is located. And I'm glad to see that building going to be
Sorry, John.
The one thing, because Irvington is gonna be a much larger facility, it could possibly be more than that, just because of the space that you'll have maybe to put an outpatient like we have at River Place. So it'll at least be the 35 to 40. I would thoroughly expect it to be more than that in there.
Marius, did you have a question?
Yeah, thank you, Brandon. I think part of the question is already been answered, but I'm sort of on a, and thank you all for being here today. Glad to have you in our county. I'm sort of on the board of a local, or excuse me, it's a regional healthcare facility that has multiple clinics all across Coalfield counties, and I know that they're having problems staffing some of those community clinics. And you're talking about, okay, I'm so happy to hear some of these potential for these 100+ jobs in their county and the level of specialists that bring with them. But where do you plan on finding these folks? We have a shortage in our local clinics now.
And
You
some of
found a job fair and you got training in mind, or where are you going to find the people to staff the clinics?
Yes, well, first of all, yes, all those things. Those problems persist across the whole nation right now, as you're aware. We actually had I'm also chairman of the Kentucky Association of Independent Recovery Organizations. We had a meeting last week in Ashland, and we had members of the General Assembly there, and they asked, there's, various treatment providers in the room. They said, raise your hand if you're having problems finding, your clinical staff. Every single hand in the room went up. So this is an acute problem everywhere. What you're talking about with your state-run hospitals, probably a staffing issue. So we do, Vanessa can talk more about that. That's part of her department. But matter of fact, why don't you just do that?
About that.
Yeah, about your recruitment efforts and training.
Let me just ask you a question. Have you got any plans to work with the local workforce development agencies?
Yes, yes. We are actively involved, and we are working with the legislature. Even this problem is so acute, it's more than even the things that you've talked about. We've talked about doing a scholarship program for training for folks, to go back to school, because that's a barrier. But this is something, even the hospitals, I'm sure you're probably experiencing the same workforce issues. They're not just in your rural communities, they're in your cities. It's the exact same thing. We're opening new centers. This is one of the big things that we look at when opening a center. But we're doing all those things, working with your workforce groups. The Kentucky legislature just invested money in a training program, where folks could actually access that money to get through training. We're doing practicums with local universities, so we establish those talent pipelines, and then we're growing our own folks too. We have a CDTC program in Kentucky, and then we're working on getting those folks up to get their clinical credentials.
We have very similar programming in Virginia as you do in Kentucky, and we have already started those conversations with the Virginia Career Works and some of the other local workforce development folks. Some of them are here today, so I hope that we'll be able to talk with them after the meeting. But I have been in contact with your HR department, and we're working to get everybody connected so that they can assist with the job fairs and with some of that as well. So
with this huge increase in mental illness and mental health issues across the country, I think all disciplines are seeing this. It's not just in recovery. We're fighting very hard. Everybody's fighting for the clinical health, and this is a crisis. This is the new epidemic in the country. In addition to the substance abuse, it's the mental health issues. These clinical staff are critical in helping address that.
Ms. Tracy.
I think that what Mr. Gates was saying, that one of the key things with Dickinson County is that our population tends to be, I can't break it down for you and give you numbers, but we have a large population that is 55 and older. We have an older, a top heavy, and there's younger folks that they're out there, they're in their communities, but they are moving away because there aren't the jobs that are here. So I think that having, and a lot of those folks gravitate toward human service fields, the field of psychology, sociology, nursing. But we end up losing a lot of our younger people because we don't necessarily have the jobs available, here in the county, or for the region, because, with the Wildwood location, of course, that's just as close to Wise County, it's on the border there. So, I think tapping into UVA Wise that is their definite votes. Because when kids graduate, a lot of times they don't have an option other than to move away and to seek employment. So, I see potential there, I think it'll take a while to get the folks there, but I see potential in terms of hopefully being able to fill some of the clinical positions.
I will add to that, when as economic developers, we look at workforce statistics. And for Dickinson County, and it's been a few months ago since we pulled the data, but at that time we had around 5,000 people, 5,000 citizens of Dickinson County who are employed. Almost 3,000 of those leave Dickinson County to go to work every day. So at the end of the day, the goal here will be, let's retain some of those people who are leaving the county for work and bring them back to the county so that they're able to work inside of the county, and that we are trying to diversify the types of employment jobs that we have. It's the same thing I hear, every day, and one of the reasons why I wanted this position and why I've worked as hard as I have a daughter who is in the 9th grade. If she chooses to stay here, I want her to be able to do that and to have opportunity, to do something, to earn a good wage, to have a good life. But I think that at the end of the day, that is the goal, is to recapture some of those folks who are leaving the county to work, who are then stopping in Wise County, Buchanan County, wherever it may be, to buy their gas, to get their groceries, and to do all of those things before they come back home to Dickinson County. So that, I think, will be the priority of targeting those individuals. I am very confident. I don't foresee that we'll be having issues with staffing, just based upon the conversation and the messages and the phone calls that I have been receiving over the past year of people who are just waiting for Art to post those jobs, who are working in Pikeville, that are working outside of the area to be able to come back home and not have as long of a commute. So maybe I'm overly optimistic, but that's okay. That's the name of my game. If no one else has any questions, I think our lunch is ready.
I'd like to make one more
Okay.
comment on that then before you close out. So the CEO of the hospital and I've been working very hard on some of this. So we got a phrase that we use, because Eastern Kentucky and Pikeville and Pike County and all Eastern Kentucky is the same as Dickinson County and Buchanan County. We lost all those jobs. So we use this phrase, let's fish where the fish are. Let's identify what jobs are here and what jobs could be here, and then let's train the people for those jobs. That's one way that we think the fastest way to be able to get the retention of our people, keep them from leaving. And so what we've been able to do, we can convince the legislature to build us a new technical school, and just so happenly, it's right beside of the rehab center at Millard. And so PMC is going to be putting 7 different opportunities for training in that facility, the same as we're keeping the welding and auto mechanics, and adding some other ones but it all is based on let's fish where the fish are. Let's identify where the jobs are, and then let's just train the people for those jobs. And we think that's the start of trying to retain our people.
And then training those people for those jobs will open up employment opportunities for folks who are not in the recovery world, and it really is a snowball effect of what we think that we're going to be able to accomplish here. So, any more questions?
Diane,
Yes,
will it be open to all localities, or we have county residents?
Oh, it will be open to any individual from the state of Virginia. So we will be treating individuals from across the Commonwealth. We anticipate upon opening, and this is my guess, not a statistic that I should be quoted on, but I would anticipate maybe 10% of the first individuals who go through treatment there, maybe from Dickinson County. I would expect that we will get, a good cross-section from all of the surrounding localities in Southwest Virginia. And if it's my understanding, I believe Vanessa's team will probably target market in Southwest Virginia first, and then expand from there.
Yeah, most definitely. And we do have statistics that people are willing to travel approximately 60 to 70 air miles away from their home to go to treatment. That's what people are actually comfortable with. So we do know that the majority of our clients, if it's their choice to come to treatment, they're going to be coming somewhere in the Southwest Virginia area, but we will treat people from all across the state.
And I just want to say, we do almost every single one of our centers is in a rural area. Some of them are more rural than others, Creekside, for instance. We have experience in staffing centers in rural areas, and I do want to say that the rural areas where you can make the biggest impact, because you're going to have 113 men at this center. Their families who are 60 miles away are going to be coming to these visitations. They're going to be stopping at your gas stations too, and they're going to be eating at your restaurants. You're going to know that we're here, not just from the people that we're treating, but from the families and from the people.
And John, just one more quick question. And we've talked about this some before, but in your experience in all of your facilities in Kentucky, and with all of the men and women that you're treating, how often do you have issues that you have to call law enforcement to come in? Is it a high security risk around your treatment centers?
No, it's not, and there's multiple layers to that. The first layer is we have a very robust intake department through the assessment. That's Vanessa's team. So they do a clinical medical assessment to make sure someone's appropriate for treatment to begin with. And so once someone comes in, then a lot of times they're being transported in. So that's kind of the second layer. The transporter says, hey, they something's not right. And then we have our own intake area. So overall, it's less than 1% of our admissions require any type of law enforcement or even ambulance. And so we've even revised our protocols. We have nurses at all our facilities. So if most times we'll transport ourselves to the hospital. The community I'm in, the population is 10,000. We have 615 people in our center. So you can see how that could really be a drain on the resources. But, when we came there initially, the local officials were very skeptical. And they are huge supporters now because of the way that we give back, and we really do try to, be self-sufficient, and we don't want to bring problems from Wise County to Dickinson County. So we try to, make sure that we're bringing people in that we can treat appropriately. And obviously, there's going to be people who, have a heart attack or have some type of diabetic thing where we do need to call the ambulance or call the police. But, our program, this therapeutic model, my office is in a place where there's 615 men, and my daughters come there. It's a safe place. You would think, I was in the Army, we would fight in the barracks. There's no fights there. I mean, it's just a safe, it's a different kind of environment because the people there, they want to be there. Nobody wants to be a drug addict, I can tell you. Nobody wants that for themselves. And a lot of times they realize this is the last door for them. This is the last opportunity. So when someone comes to our center and creates a problem, we have a list we call the IFS list. It stands for ineligible for service. Once they're on that list, they're not eligible to come back to an ARC facility for a period of time. That's a tough pill to swallow for somebody who wants to get better. So people, there's really a communal effort to get through the program and to make it and to be successful. And we see miracles happen overwhelmingly every single day in our center. So the problems, I know it's a really long answer.
That's okay.
But I'm a politician. You give me a microphone.
I'm not a politician, but I will say that when I came here, I was actually a little nervous. It was a very small facility. When I started, I was the only female at that facility. And, my first day, I'm like, I don't know what's going to happen. I was really freaked out. And I could not believe the amount of respect that the clients give the staff members. They hold each other accountable. No one is, they're not rude. As a nurse, I've been a nurse for, 11 years, I think now, maybe 13, I don't know. Anyway, however long, I've never been respected like I am here. It's made it makes a huge difference. And it is kind of a slow gratification instead of that instant, you don't see them instantly, but just like they said, there's going to be 112, 113 people, and each of those people have children, have parents, have whoever. So when you're working with them, you have to think about, you're not just helping them, you're, helping their whole family or their loved ones. And once you see them actually make that change and you see them get their children back, you see them buying a house, you see them, finding love later on, whatever. It is a huge blessing to you as a person working there. So I think it's a very safe, I've never felt unsafe.
Well, I smell the barbecue.
I worked there for 2.5 years, and we caught public full time. We had a lot.
2.5 years.
Where I work embrace us here, and, it's great.
And I know everybody wants to go to lunch, but I want to say a couple of things, kind of ease the sheriff's mind. We do less than 1% of the transports per year. When we started out before COVID, we done a lot more. Now, most of the time, when Art calls me, they've already booked up, it's gonna be 3 or 4 days, and we kind of do those with court order from the district judge of goodness of the heart, and I think that's been one in last year. And as far as community partners, anytime I speak with someone with Art, it's always me asking for something, they're really never asking me for anything. And as far as the process of getting in, you don't have to be in trouble, you don't have to be in the ER. Like I said, we started care before Cubs, they come into my office, I contact them, they do the assessment there, and they talk to them, and they get them in most of the time the next day, and sometimes that day, or 2 or 3 days after. So, I mean, they don't even have to be in trouble. They call from their home, any office, anything, so it's a blessing that they're coming to your community, I can tell you that.
Yeah, and we're large enough now where we have enough beds where, maybe someone gets admitted here at Wildwood and they're just not appropriate for that center, and we can transfer them to River Place. In fact, we can internally transfer clients. We do that a lot. Like I said, where my office is, it's gigantic. Most towns in Kentucky don't have that many people. So if someone's from Boonville, Kentucky, and then there's a population of 300, and now all of a sudden they're in Crown and there's 600. It may be overwhelming, and we can transfer them to a place smaller. Mia Center has very few people. It's in a neighborhood. It's two separate houses in a residential neighborhood, and they don't have problems. And I think that speaks largely for us. And at Crown, by the way, with those 615 beds, we share a parking lot with a home for retired nuns. So you cannot have more population. And
They love us.
and you see these old ladies walking through the parking lot in the morning doing their exercise. So I love that. I love that relationship, and we want to have that everywhere that we are.
All right, I smell the barbecue. So we're going to go through these doors over here, and you circle around to the back. And we have barbecue and tea and all kinds of good stuff. So we hope that you'll be able to stay with us and have lunch and chat with some of these folks further. So thank you all so much for being here. We truly appreciate you.